How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, they're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Keira Deneen. I'm a certified genetic counselor and your host. Have you heard of TrackGene? TrackGene is a clinical genetic software solution used by over 1,000 genetic experts around the world. You can customize the front page so it's streamlined to your specific workflow. The intuitive patient information entry page makes data entry efficient and user-friendly. Pedigrees are also easy to draw and document. Here's another vital feature. It supports HL7 integration to be used with other clinical genetic software, databases, and hospital information systems. So you can build custom reports with the simple drag and drop report builder. This has an interface with data visualization tools such as those from Microsoft to make it easy workflow. And there's more features on the way, all designed with you in mind as the genetics expert. TrackGene has an experienced team who's been working in the clinical genetic industry for, get this, over 15 years. You can request a demo for free. Go to trackgene.com. Again, that's TRAK Gene, so track without the C.com. Stay tuned for upcoming episodes of DNA Today, where we're going to be chatting with TrackGene. When Willow was diagnosed with MSD, her mother Amber was told to love and care for Willow, but that there was no cure for this terrible fatal condition. Amber set out to find and fund the cure for MSD. That's when she started the United Multiple Sulfatase Deficiency Foundation. She shares this personal experience on episode 205 of DNA Today, including how this affected her family and the relationship she has built with other families in the MSD community. Check out episode 205 to hear this inspiring interview, and be sure to visit curemsd.org to donate. Again, that's curemsd.org. Joining me is the lovely Dr. Lora Bean. She is a clinical molecular geneticist, and she serves as the Senior Director of Quality Assurance at PerkinElmer Genomics. In this episode, we're chatting about phenotypically-driven clinical results. So thanks so much for coming on and diving into all this.
Thanks for having me.
I think it's helpful for people if we remind them, or maybe teach some new listeners, the difference between a gene panel, an exome, and a genome, because I feel like we're going to refer to this a lot during the interview. Would you mind giving us like the basic elevator pitch on what the differences for those are?
Sure. So the basic techniques that we're talking about here is sequencing what we want to sequence out of the genome by next generation sequencing. And when we first started doing these large scale sequencing, it used to be even doing a large gene was hard. We did it by Sanger, one little piece at a time. And even there, you had to amplify what you want away from the other 9 billion bases in the genome so that there was enough of that versus everything else to sequence. So the first NGS techniques were either amplicon based, which can scale to a point, but you can only amplify so many fragments, at a time. So where we really got to larger gene panels was being able to do a capture method. So this is where, how to get what you want? Well, you make a whole bunch of little single-stranded probes that match the genes that you want, and you can do lots of these, and you use a capture or a pull-down method, and this capitalizes on the whole basic principle of molecular biology. All of molecular biology works because single-stranded DNA will bind to complementary single-stranded DNA and make double-stranded DNA. That is how every one of our techniques works. So when you want to capture, or we call this targeted assays, pull down, we make little probes, little capture probes to go get what we want and pull this down out of the genome. So you can do this with just a few genes, and ultimately we got good enough at these techniques to do an entire exome. So all of the exons of an exome is about 4,000 coding genes. We have libraries that are even bigger to get to more like all 20,000 genes. You pull those down, and now you just have the parts of the genome that you're interested in sequencing. And so you've captured it, and you've sequenced it. And then you can do that in a targeted way. We have little tiny capture libraries that will just do, say, the DMD gene. And that used to be one of those really big genes that was hard to sequence.
And it's
but
one of the biggest genes in the genome, right?
It is one of the bigger ones, yes, 79 exons, and that's considered a very small capture. You can do a panel of genes like this. You can go all the way up to the exome. So you can capture and sequence. And even at that exome, you're sequencing 1 or 2% of the genome. Now, as sequencing got less expensive, we were able to just do genome sequence, which is generating a massive amount of data. And that one genome there was an entire genome project that took like a decade to do one genome, and all these techniques were developed, and many of them coming out of that project, and we can do a whole bunch of them all together right now, this week. So being able to sequence, so in genome sequencing, that's actually technically really easy. You chop up the genome into pieces, and there's a few enzymatic steps required, but basically you chop it up and you sequence it. And then you have everything. So going from a capture, it's how much do we want? Are you really interested in just 1 or 2 genes? And you can generate a small library, and small data costs less than big data. So depending on what you want, if you're diagnosing a child with a complex medical disorder, and we may or may not know what this disorder is right now, you want to get as much sequence as you possibly can. Look at it now, look at it a year from now, look at it when we're able to go analyze lots of other regions of the genome, or have that data set. There's good reasons to do that. But if you're just interested in one gene, and we're seeing many drugs starting to enter clinical trials for genetic disorders, and sometimes those projects are interested in one gene in one group of people, and that's all they need. So really, it's about what are you looking for? What do you need, and what do you want? So whether you're going to do a panel, an exome, or a genome really depends on what you want out of that DNA sequence.
I think that's such a good way of putting it, because you're also highlighting that there will always be a use of just sequencing one gene. That I don't think that's going to fall by the wayside, because if you have a diagnosis of a condition like, let's say, DMD, and you're saying, well, we want to confirm the diagnosis, we're just sequencing that one gene. We don't necessarily need to do a whole panel of muscular dystrophies, for example, if we already know clinically we're diagnosing as DMD. So I think that would be like an example of, okay, it's useful to just do one gene. Now, gene panel, if you're like, we're not sure, it's some kind of muscular dystrophy, then you're doing a whole panel. But maybe, as we've done in recent history, it's ordering that panel. But are panels going to not be as useful anymore? Are we just going to go from, okay, if we have the single gene, we'll go for that. But will the next step become exome? Because, as you said, it's also really helpful to look back at that data years and years later, especially for rare diseases where someone doesn't get a diagnosis right away, but maybe then we figure out more about that gene and that variant. So, I don't know, what are your thoughts on that?
Well, it really depends on the situation, and we have to consider, yes, there's the technology, and we're talking about the technology, and so we have to remember there's what we can do, what we would like to do, and what is considered standard of care in the healthcare system, which goes to what is somebody going to pay for? And so all of this comes at a cost. There's a cost to patients, there's a cost to the healthcare system, while we don't like to focus on, well, what does it cost? That is a driving factor, and it's important for patients. It's reality. So there's what we can do, what we would like to do, and then the practical, well, what should we do right now?
And we need to make a meme of this with the different images of what we're thinking.
Yes. And we definitely need a meme of this.
Great. I'll get my social media team on that.
And so, but I think we're limited. That can limit us as well, because if you're restricted to say, well, a panel costs less. Okay, true. But if you don't get an answer, you're going to go on and you're going to go order another test. So, what is what do we do first? What do we do second? It really comes back to that clinical use scenario. If you know that a boy has DMD and there's a clinical trial and you're looking for eligibility, sequence that gene. That's what we're doing. And there are disorders where the genetics are pretty well worked out. Maybe we're running a newborn screening program, for example. We do a lot of newborn screening, and maybe we have a little small library that just has genes for disorders detected by newborn screening, and it's part of the follow-up program. Newborn screening programs, right now, are they able to pay for a genome on everybody? No, that's not in their budget. Would we like to do that? Well, some people would, and there's a whole other discussion to be had there. But what do we need, and what is the most responsible use of healthcare dollars right now? Knowing that what has the lowest price tag might not be what's really best for the patient, and that's where we get into complex phenotypes, multiple congenital abnormalities in newborns, and there are statements from the ACMG saying, look, if you have a newborn who has significant issues, exome is a first-line test.
And you can do it rapid.
We can, and that's important as well. So when I said genome is actually technically simpler, then you chop up the DNA and you go. You save several days doing that in the processing step. You can get to a sequencer we can get data out within 2 days.
That's pretty fast.
And that's because the technique to do this, the molecular technique, there's just not very many steps. It's basically chop and go. And so that becomes much faster. And there's certainly, good use cases out there of where getting that answer for that newborn, particularly around seizures and epilepsy and seizing newborn. If you know why, directed treatment there. That's the, I guess it's going to become the classic example of a rapid. But there's many cases to be made there around management, around predicting outcome or prognosis.
And I think when we're looking at cases like this, as you said, it's going to become like the poster baby for okay, when are we doing this rapid genome exome? But I think one thing that I worry about as a genetic counselor of doing more and more whole genome sequencing is, we're going to have a flood of variants coming at us. If you're looking at all of the variants in someone's genome, a certain percentage are going to be different than our reference genome, like our quote-unquote normal typical genome.
Sure.
Because that's the beautiful aspect of human diversity. So, how can we limit this? Because, it's just exome is one level, but then to go to genome and having more of this, I'm a little nervous. How am I going to sort through all this?
Well, first of all, a good laboratory is not going to give you big unwieldy lists and tell you good luck. Yes, the data are sitting, and yes, we can make a list. Without clinical utility, a laboratory should not be saying, here you go, have fun with that. Good luck. Yes, those variants are sitting there, but that doesn't mean that we have to go one by one and say, well, we don't know. But we know where to go look, right? This is where, the ACMG has said, here are actionable genes. Look there.
And what number are we at now? Because for a while it was 59, now it's 74, something like that.
I was about to say, whatever that, it's 73, 74, it's,
right.
You're right.
Look in the show notes, I'll put the correct number in there.
Okay. But that's the purpose. That's the purpose of professional guidelines like that. Well, what do we want to look at? And how are we going to interpret the variants? We have professional guidelines for that too. And ultimately we can make lots of lists. There are genes associated with recessive disorders that have carrier frequencies in the population, and many labs will say, here's our carrier list. This is where we can responsibly say, if there's a pathogenic variant in this gene, you're a carrier for this disorder. And So by instead of saying, here's all this stuff, what are we going to do with it? We say, okay, we have a genome. That's great. We expect most of it to be there. What do we want? We want medically actionable genes. We want carrier status. And we want variants in genes associated with phenotype. This is where we want to go look. Because a laboratory making a giant list for you as a healthcare provider, it's not helpful. And, while we have that data, we can go back to it. And that is, there are now some reimbursement codes for reanalysis. Those CPT codes are coming out.
Wow.
Yes, and there's, whether or not, how that actually looks in terms of, what gets, paid for.
It's a step in the right direction.
But, this is where a new technology, you're always going to be pushing the technology forward and everything else has to catch up. I just gave a talk on a quality QC materials for developing and maintaining NGS assays. Well, you develop a bunch of new assays and a bunch of new technologies, guess what? There aren't the reference materials out there. You have to go develop them because now there's a need. And so same thing, with, how we're going to explain this to the the healthcare system. We have this technology and we can show that it is good for patients, that it has clinical utility, but that all has to come kind of push and pull as you go. So
as a healthcare provider, I can help this process by, let's say I worked in peds, right? In pediatric, I'm working with kids, and I have this kid that has features like, you were saying before, like they have seizures, they have other things. That's really helpful for me when I'm ordering from you guys to say, hey, here's a heads up. These are the issues, or this is the phenotype, right? Like, oh, the ears are rotated differently, or different things that we point out in genetics. Where are the eyes closer together, further together?
Yes.
For me to tell the lab that's going to help, because then they'll be like, ooh, we'll look at these genes first, because Kira said that these are the symptoms. Which,
yes.
I mean, are there other things, like I'm just off the top of my head saying things, but are there common ones that you're like, if I could just get in genetic counselors' ears, healthcare providers' ears, please include this on the requisition when you order the test?
Oh, what I really
What's your wish list?
I want to know if a child with developmental delay is verbal or nonverbal. And you'd be surprised how often we can't tell. And it's not the geneticists that are the biggest offenders on that. But, we often, when you have a 5-year-old and there's a description, or you only get the list of clinical features, developmental delay could be, I had a case several years ago where from the list of features, even repetitive movements and regression, and I was thinking Rett syndrome or a Rett-like syndrome. I was really thinking this. And then we got a clinic note, and I'm reading the clinic note, and this child was a girl in a normal 5th grade classroom who could work on grade level as long as she was allowed to work under a blanket.
So that's very different than someone
Right.
that is nonverbal and needing a lot of extra support in school.
Right. And so that's not normal, but that's also not Rett syndrome.
No.
And so having that context, when you say developmental delay,
I mean, that's like the most
Okay.
generic term you can say. Like when someone says,
And
like, what desserts do you like? I like chocolate. You're like, what dessert isn't chocolate? Right? It's just like so generic.
sweet. I like sweet.
Yeah, like sweet. That's a better example. Thank you, Dr. B. Yeah.
But when you go try to start pulling genes, and we played around with this a little bit at one point, taking the giant list of clinical features and narrowing it down, trying to be specific. And the genetic counselor I was working with at the time, she and I had a list of rules, and we always included things like specific facial features. That was always included in our narrow, we called it a wide and a narrow, the narrow. But then the developmental delay, if we had developmental delay, we didn't necessarily include language delay. Or if it was like there were certain big broad terms where we would say, okay, well, which one, based on what we have, is really describing? Or if we had language delay, we wouldn't include developmental. Or if we had hypotonia and verbal delays, exclude some of the broader terms. And we were able
Get
to...
as specific as you can, more narrows, less wide.
Yes, and we were able to cut the number of variants, in genes that we were looking at by 2/3 or so, but still keep everything that we ended up reporting, like out of a series of cases. And so just having that specificity, particularly around dysmorphic features.
That's another very
Is it a
generic
nose?
one.
Like,
I can't imagine writing that on a requisition. Again, I don't work in pediatric, I work in prenatal, so it's a little bit different. But, when I have ultrasound findings, I don't write, like, abnormal ultrasound finding. Like, I write what it is. Like, yeah, I think that's one for... That applies to probably every area of healthcare, I would say, not just us in genetics.
Yeah, and we've had people come back and say, well, what about this? I say, well... yeah, okay, but we weren't getting this out of what you were describing. And so in trying not to flood the healthcare provider with 20 things to consider, we have to get it down to, what looks the most rare, the most suspicious, the most like, this is our best match. And if our best match isn't based on the best description, particularly when it comes to reporting, say, a single variant in a recessive disorder, when do you do that? Well, it's got to be, if your only indicator is developmental delay, well, either you need to let the 20 VUSs in that are single hits in recessive disorders, or you let none of them in. You have to have something that, if you're at 20, that's not helpful. And we're not getting what we're looking for.
And in those situations, like, how helpful is trio testing, where you have the patient that is typically, in the cases we're talking about, a child, and then you have the biological parents. I mean, what, I'm throwing a curveball question at you, but what, you're like, I love it. What percentage of, like, let's say this imaginary case, you have 20 variants of unknown significance. You say, we don't know if this is causing disease or it's just normal human variants. How many are you typically able to rule out based on healthy parents having one of those?
Anything in the dominant condition, if the disorder is dominant. But what's really valuable there is what you can rule in. If one's de novo,
neither parent has this. That's interesting. Where did this come from?
Right. And so and we do see de novo things happen that are not disease causing. You see somewhere between 0 and 5 in genes associated with disease, but most of those de novo variants, if they're in recessive, they may be in recessive genes, or they may be silent. De novo things happen, and but if you're in a dominant disorder, it's a missense, or maybe a gene that's not very well characterized, that you don't have a lot of good information on unless you really know to go digging. It's not coming easily out of, databases yet. Maybe there's not much published, maybe, but you have something de novo, then to go spend the time there. And, even if, there's this line to walk between, I think this is it, here, you should really consider this, versus, this looks suspicious. I don't know what this means, but you need to hang on to that, and you need to check the literature, and you need to not lose track of that variant. And you have to walk this line around clinical utility of, is this gene definitively associated with disease? Are there 20 patients out there? Can you make a diagnosis on this alone? Well, not always, but we're not going to say, here, there's 2 patients described, it's associated with disorder. That's going to be a C interpretation. Hey, this patient looks like these other 2, maybe a little bit. We really don't know if this de novo is going to go on to be this child's diagnosis, but you want to keep an eye on that, because we have to think that, this may be the only genetic test this child ever gets. And if it's completely non-diagnostic, non-interesting, nothing to follow up, they may never come back. So we have to walk this line between not over-interpreting based on the available information. We don't want to jump to conclusions, and we certainly don't want to give someone a diagnosis that is going to turn out to be incorrect. But we need to present the available information in a responsible way to say, that, and this, a good example of this is, maybe we do a quad where there's 2 affected kids, and they happen to be, when you sift through all of that data, they're both homozygous for the same variant in a gene that maybe has a weak association, or the parents are both heterozygous.
So are these siblings to each other if it's a quad?
Siblings to each other in this
full siblings,
quad.
you got the parents, you're doing all 4 of them. Okay.
And and maybe we say, we don't know if this gene is it, but you might want to keep an eye on that. And see if, and go to the matchmaker sites and, see if anyone else is seeing anything in this gene. But we have to report that in a way that is, so clinical testing cannot be a research project. We cannot discover a gene because a sample was submitted for clinical testing. That's not what we do. It is not the right set of things to do. We can identify things that look suspicious, and we can disclose that with all of the caveats of, we're not all the way there, but you might want to keep an eye on it.
Yeah, definitely. I think it's helpful to know, and I think you also really are highlighting that it's important to have these case studies, because the more you have, if you have, like you said, 20 cases where kids have been diagnosed through a certain, genetic variant, then you can say, wow, I don't know if that's the actual number, but like at some point, you get to enough where you say, our N number's high enough where we can say this is pathogenic, and that's part of the classifying of the variants. So it's so important to actually have that, because if you have just like a couple out there, you're like, well, is that really causing it? Or is that like an incidental finding? Like it just happens to be there, and it's not actually causing it. TrackGene has designed a genetics electronic health record. Here's what it features: pedigrees, demographic data, genetics information, risk tools, and sophisticated reporting, all within a clinician-designed workflow. It integrates with other clinical genetic software, databases, and hospital information systems to maintain accurate patient records. Go check it out at trakgene.com. Again, that's TrackGene without the C.com. And keep your eye out for our full episode interviews with TrackGene coming soon to DNA Today. Amber Olson founded the United Multiple Sulfatase Deficiency Foundation after her daughter Willow was diagnosed. I learned more about MSD in episode 205 of DNA Today, when Amber opened up about Willow's care and the development for a cure for MSD. So MSD is caused by an issue with lysosomes in our cells not being able to break down toxins in the body. So instead, the toxins build up in the body, leading to a neurodegenerative condition. Faith McGowan also joined us in this episode. She has 30 years of experience in nonprofit fundraising and provided helpful tips and a mindset for fellow nonprofits when they're coming up with their strategies to raise money. You can listen to the full interview on episode 205 of DNA Today. Head over to their website, curemsd.org, for advice for family members who recently received an MSD diagnosis, resources for healthcare providers, and to donate towards funding the cure. Again, that's curemsd.org. So I think my last question, because I can't believe we're almost at the end of the episode. This is wild. It's gone so
really
fast. I know, so fast.
We'll have to talk again.
I know, right? We're going to have to do like a part 2 at some point. So with all of this, like, shifting and maybe just more including whole genome sequencing, I imagine a lot of variants that we don't know yet, these, VUSs, VUS, however we're saying it.
Yeah.
A lot of these are going to be very deep into the intron. So exome, we're looking at just the exons, the quote-unquote active part of the gene. And then the introns are kind of like, the backstage people that are running the whole show. So how often are we finding variants in these like super deep into the introns? And we say, well, we're going to have to get a lot more research, because we've only been doing whole genome sequencing for, a few years, maybe a little more than that, but at least at the level that we've been doing it now.
So it's a really good question, and I think there's a couple of ways to think about it. First is we know from the genome projects, from all of the sequencing that's been done, that there's a lot more normal variation in introns than there are in exons, which totally makes sense, right? You have all of the sequence, and changing any one base pair is pretty unlikely to do something to the gene function. Now, where you get into right up close to an exon, those specific base pairs, your plus and minus ones and twos, they have very specific functions. You can't change them. So you see pathogenic variants there.
Because that can turn genes on and off. Like, that's really going to mess with
it. Disrupts splice. It disrupts normal splicing, and you got to splice your exons. So they have really important jobs, and if you change them, they don't do their jobs. So now think about, you have many KB in an intron. How many of those base pairs have a specific job? Very few. And how many random changes are actually going to change the splicing of a gene? Very few. But when there is a deep intronic variant, when a patient is, and it is I think it's a rare exception that you have something deep intronic or in a regulatory reason that's causing disease, they are the rare exceptions to the rare diseases. But for them, it's everything. That is their cause, and that is why it's so important that we do move on to finding those rare exceptions and identifying them. But they're going to be rare, and so I think what you're getting at, has been, talked about over time as the missing heritability. We have things that we think or know are genetic, but where are the variants? Well, maybe they're deep intronic, maybe they're regulatory, maybe, and some of them will be. I think we're going to see bigger genomic architecture kinds of things that cause these more complex disorders, and just to also point out, for genes where we know that a patient has, say, 2 variants in that gene, they have galactosemia, they have PKU, they have, we know the gene. We find both variants. We sequence and we find in a very large percent of cases. That's up in the 99 point something range. So it's not that we're missing half the disease-causing variants and they're sitting deep in introns. They're going to be relatively rare, but we do need to find them, because for those patients that have them, that's everything. And we think about rare disease. We think about rare patients and how best to serve. And so as we're better able to do things like transcriptome analysis, that then, we get to the point, and then the level of complexity there is even higher, because it turns out our genes are only so good at splicing to begin with. We think about this in a very nice black and white way. Here, everything works, and we get these
that doesn't apply
variants.
to genetics. Nothing. Nothing is black and white.
And transcriptome data for some of these genes, yeah, sometimes it works, sometimes it doesn't. As long as you hit it most of the time, it's fine. Well, how do you know when one of those, and so this is where I think we're going to see, a huge building of databases. We thought, the 1,000 genomes and the 100,000 genomes and the was big. I think that there's a lot of resource out there that is still being developed that's going to help us get at some of these things. And it's certainly out there, and it's certainly worth doing. But I don't think that's going to be the magic answer to our missing heritability.
Yes. Yeah. I think that's a good point, and something that we can, there's always new technologies and ideas on the horizon in genetics to look forward to. And certainly when all that happens, we'll just have to have you back on so that you can explain all this again to us. Because genetics changes fast. We've been doing the show for 10 years, and all this intron, we used to call it junk DNA when the show started in 2012, because that's what it was. And we know now it is not junk. And I remember sitting in high school, listeners of the show have probably heard this before, but I remember sitting in high school biology in sophomore year. So this is around, let's say 2010. And, the teacher was like, yeah, it's called junk DNA. I was like, how could that much of our genome be junk? I was like, I don't believe it.
Not buying it.
I was like, nah, it's got to do something. So that's my claim to fame, that I'm like, I knew it back then. I mean, probably a lot of people said that. Yeah. But, as a 14-year-old, I was like, I don't think so. But yeah, no, it's so interesting, and it's just, I can't wait to see in another 10 years, where we're at with all of this testing and variants being so much easier to classify because we have so much bigger databases, like you mentioned, like the 100,000 Genome Project. We actually have an episode coming up with them. So, you know, it's so interesting. But oh my gosh, Dr. Bean, I could talk to you forever. You're just so engaging.
So I should get in there with, you know, after I've dismissed the deep intronic sequencing, right? That I didn't really. But what genome sequencing does get us, because you just chop it and go, you get this beautiful even coverage across the genome. And this is where we found that we're able to call very small copy number variants, because we don't have spiky data, you know, of here's lots of coverage on an exon and another one and another one, and did anything move in that deep, you know, in having additional depth that would be a duplication, or loss of depth of coverage that would be a deletion. The genome coverage is just, it looks like a high resolution microarray, and it's even better. You can go down to the base pair, but it's just gorgeous data. And even unbiased sequencing just has to be better for lots of things, you know, than what we need to do when we're capturing. And you have all those additional steps of binding and pulling down, and then having to do some level of amplification after that. Well, you know, how are we doing on, you know, allele balance and things like that? The genome sequence is just nice and clean, and you get about 30, 40x. So mosaicisms, you know, if you're looking for mosaicism, deeper coverage, you know, it's still better. But again, it's this use case. Like, what are you trying to do? And what does it get you? But what we found in the most immediate term is the resolution of copy number variants is so much better, because the data are just nice and clean and even.
Yes,
and
definitely.
So that's something that you do get with genome. And we're working on, you know, there's algorithms, you know, in development to do even more, to look for rearrangements, to scan for, you know, when you have all of this nice even data, and, you know, and eventually we'll have long range, which will.
Yes. Yeah, that is kind of the next
topic,
frontier. And you did a fantastic presentation at NSGC in 2021.
Thank you.
So I'm definitely going to put a link in the show notes to that, because there's a full video of it. And a lot of what you're describing right now with like the spikes and everything, you do such a good job of like zooming in and expling that part. And I come from a cytogenetics background.
That's better than me doing this right now.
Well, hey, you know, I love it. It's like a TikTok dance. It's great. But for people that really want to dive into the data, you know, you had a little bit more time there, so you dove into a lot, and there was a lot of great questions at the end from the audience. But we'll put a link in the show notes for that. And just thank you so much, Dr. Bean, for coming on. You're just such a delight.
Oh, well, this was really fun to do. Thank you for having me.
For more information about today's episode, visit DNApodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@DNApodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Keir Deneen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me are all made of DNA. We're all made of the same chemical DNA.